Hello and good afternoon. I hope you are enjoying all the previous lectures. For me, it's has been amazing to share with you these classes that I think that they are, at least to me, they are the principles and the basis for implant treatment. I hope that I've been helping you with your clinical cases. Nevertheless, I want to thank you all for following me, also on the social media, and also for asking me for advices and sharing with me the cases. So I truly appreciate that. Thank you very much. So please don't be shy and continue to do that. Today, I'm going to share a little bit about the post-op care of implant treatment. This is actually, I think, one of the most important thing that we have to be aware, because not only we want to have immediate success, but we want to have long-term success. So in order to have long-term success, we have to follow our patients through the years. So not only after the surgery, but after the rehabilitation, and well, during the years for their maintenance. So this is very, very important. And usually I say to the patients, on the day of the surgery is when everything starts. So today we are going to talk a little bit about the pre and post-op care, patient compliance and maintenance. So we know that it's important, and many people talk to me about and ask me, what kind of medication do you give to your patient? So I'm going to go through that also, to understand the need for implant maintenance and also these protocols of compliance. I'm going to share with you the protocols that I use, that we use at our clinic, but you don't have to follow exact the same protocols. Of course, if you want, you are more than welcome to use them, but the thing is to create your own protocols, because you have to adapt to where you are and also to the patients that you have. So first of all, and before starting, it's very important that we have to understand that we have several goals when we rehabilitate our patients. And of course, we want our implant to osteointegrate and to have success. But also from the success, it's important to understand that patients don't want implants. They want to have aesthetic and functional teeth, so fixed teeth. And for that, it's very important that we are aware of any changes that might occur in terms of the bone or the soft tissue. So around our implants, what we want is we want to have stability in our tissues around our implants, meaning the bone and the soft tissue, so that also our restorations, they continue to be aesthetic and functional. So these goals are very, very important, because we always have to be aware. And of course, everything can be amazing in the day of the surgery, can be even better 4 months after the surgery when you go for the final procedures. But the big goal here is that it will last, if possible, for a lifetime. So in order to achieve that, and at least to be able to solve whatever happens to your patients, any kind of complications, might it be in the soft tissue, might it be in the crowns of your patients, if they unscrew or if they break, you have to be in a compliant way with your patients, always together, and having these maintenance appointments every year for a lifetime. So before we started treatment, we talked about this already, about the pre-treatment evaluation, to evaluate not only what kind of treatment we are delivering to our patient, but also the type of patient that you have in front of you. So it's important to understand who this patient is, in terms of systemic, what kind of patient you have. Does he have any systemic condition that you have to be aware of, and you have to take care before starting the surgery. So these systemic guidelines of the patient medical conditions are very important, that you follow a good medical history of your patient, that you know all the medication that they are taking, and that you know in terms of ASA classification what type of patient do you have. Because some of these medications that patient take, or some systemic conditions, they might interfere with bone metabolism, with the healing of the implants, and of course then afterwards about the implant therapy success. So it's crucial to evaluate your patient's medical history, and if necessary, you will get in contact with his physician in order to understand how to deal with your patient. If you have to stop any medication, if you have to wait a little bit more in terms of controlling your patient, well, basically this is something that you have to be aware before the surgery and talk to the physician of your patient. Another thing that it's very, very important is that basically when we talk about factors that may increase infection risk around implants, we know that in terms of, there are systemic factors, there are local factors, and surgical factors. So basically this was reported very well by Mission 2008. So which ones can you influence? And you can influence in a positive way to basically avoid this kind of infection risks around your implants. So when we talk about systemic factors, basically we have to understand in terms of diabetes, if we have a control patient, try to diminish the smoking habits of your patients, to know if he's taking corticoid therapy, if he's immunocompromised, how is the nutrition, if he's obesity. So all these factors from diabetes to being ASA 3 or ASA 4 patient, of course, will then increase the risk of infection around your implants when compared with a normal patient that does not have these systemic conditions. So again, whenever needed, try to make your patients transform this kind of risk that they have. Diabetes, try to control diabetes. In terms of smoking, try to avoid smoking, or try them make them aware that smoking habits can basically increase the risk around the implants and diminish the success rates of implants. So if they can avoid smoking, if they can quit smoking, better. So all of these we have to take in consideration. Other local factors like bone grafting materials that sometimes are moving, previous periodontal disease, any odontogenic infections or tissue inflammations that we might have, inadaptation of provisional prosthesis, the surgical incision line, and bad oral hygiene are all local factors that can increase infection of around the risk of infection around your implants. So if possible, try to avoid bone grafting material. We use it only for some cases, and when you use bone grafting material, be aware that it is completely stable, that it's not moving. So this is very important. In terms of periodontal disease, as I said before, try to control, we have to control the periodontal disease before going into implant treatment surgery. Why? Because we know that the periodontal pathogens are also can cause also inflammation and infections on the tissues around our implants. So they can also lead to some peri-implantitis. So it's important that you have also the periodontal disease completely controlled. Any odontogenic infections might be taken before any implant surgery. So if you have, for example, periapical infections in the neighboring teeth, please endodontic treatment on these teeth before you do the implant surgery. The same with tissue inflammation, very important to instruct before the surgery very, very, very well that the oral hygiene habits, so that the patient also gets to get other types of habits of oral hygiene. Um, for the cases of immediate function, in the adaptation of provision of prosthesis is very important to understand that this can create infection around the implant. Why? Because then the accumulation of bacterial plaque is higher and it's much more difficult to remove it. Besides this, of course, you can have tension in your prosthesis if it's, for example, a breach where if you don't have a good adaptation, if you don't have a good passive fit of your prosthesis, it can lead also to breaking of the prosthesis. Also, the surgical incision line, very important, as I stated before, in the manipulation of the tissues to try to get afterwards, after the healing, keratinized tissues around your implants. So very important how you design the surgical incision line of your surgery. Also very important is, in terms of surgical factors, the aseptic technique. So very important that you have a good aseptic technique during the surgery, not only by the clinician, but also all the team, all the assistants. The experience of the clinician also plays a role in the risk of infection around the implants. As more experienced the clinician is, as lower the risk of infection is. Longer procedures have, of course, a higher risk of infections. More than 3 hours, we see a rate of 4% of risk of infection, and also the contamination of the surgical wound during the procedure. So keep it as more aseptic as possible and more clean as possible with good with very experienced, not a clinician, not only the clinician, but also the team. So it's important to have good education if you want to get more experience, to learn the same as you are doing right now. So these factors are important factors that we have to take into consideration, that we know that will increase the risk of infection around the implants, and some of them we can avoid, or we can actually diminish the possibilities of risk infection around the implants, being it on the systemic factors, on the local factors, or on the surgical factors. Now I want to share a case with you, because I would like you to see a case from the start to the finish in the day of the surgery, in order to understand how we prepare the prosthesis before, how you can prepare the prosthesis before, how we do this, and how we deliver in the day of the surgery. So this is a patient that we want to go for all-on-4 upper and lower jaw. And this is our appointment where we see the patient before the surgery, and where we start to basically to plan our case. So what we do impression on the upper and on the lower jaw of the patient with what the patient is having. Also, we make a bite registration, okay, and we know exactly the condition that we have of our patient. Now we start to control and to say how we want the occlusal line to be designed in the future prosthesis, and where we want our middle line to be. So what we are going to do is, basically here we are controlling the vertical dimension. We are checking if we want to diminish, if we want to increase, if you want to maintain the vertical dimension after the surgery. So here we have all of this, and we send the impressions to the lab. As we send the impressions to the lab, basically we have the two stone models which they will articulate. So in this in the pre-surgical appointment, we take pictures of the patient, the before pictures with the smile, with the rest position. We check on the smile line, we check on the vertical dimension, we check on the lip support, all of this. Now we did the impressions, and what we are going to create, we are doing the surgery exactly in the models, what we are going to do afterwards in the mouth of the patient, we are doing it in the models. So meaning that we are going to prepare like it would be an immediate removable, total removable denture. So we prepare the setting with our prosthesis. Here we can see upper and lower. Okay, so what we are going to build, we are going to have like 2 total removable dentures. So we decided here that we wanted to remove about 3-4 millimeters of bone. So that's also what we did in the lab. So every time we have a feedback also from the lab to check if we have sufficient space to place the 2 bridges, or if we also need, for example, to trim the bone because of prosthetic space. So this is very important, and this is the work that they are doing in the lab. So this is the analogical way of doing it. We do this, we trim. It's exactly like doing a removable upper and lower denture, as you can see here. Good. So after this, what we will do is that we will have these 2 removable dentures to be able to be adapted in the day of the surgery. Of course, we can check also any details here that we don't want to interfere in the mouth of the patient. We do the bridges here just till first molar because we won't have more than 12 teeth. And for the provisional bridge, we will basically have the teeth till the last implant, which means that we want to avoid cantilever as much as possible in this first phase. Good. So at the end, we do this bite registration because it can help us to stabilize also the prosthesis in the day of the surgery to help us to realign the dentures. So after this, what do? We go into the surgery. So we go into the surgery, we start the surgery. As you know, we start by extracting all the teeth. So we extract all the teeth, very aseptic surgery, clean, always wash very well, have the tissues wet, clean all the tissues that you have there, all the granuloma and the apical roots of your tooth. And here we can see we trimmed the bone like we had decided because of the smile line. We go into the middle line, we make sure that it's perpendicular to the papillary line. We see where's the interior wall of the sinus, we probe the interior wall of the sinus, and we start our drilling. So we start our drilling, and we are going to drill according to the type of bone that we have. So we'll drill less or we'll drill more. After this, we'll connect our abutment. Here's our abutment guide. We use our bone mill and we connect the 30-degree 4.5 millimeters abutment. After having done the posterior implants, we go for the anterior ones. Okay, so in the front we go with our implants. If we have very soft bone, we aim for a bicortical anchorage. Because we have trimmed the bone, we also trim a little bit of the gum from the palatal side, and now we are going to do the impression. So we do the impression, we fertilize the impression copings, make a union between them. Good. And we use just putty silicone. So our patient has come, as you have seen, for the pre-treatment appointment. Okay, So in this pre-treatment appointment, also the patient goes and does an oral hygiene appointment to make a prophylaxis before the surgery. Okay. On the day of the surgery, although we start with the upper jaw, before the surgery, the patient will be given immediately will be given also the medication that they are going to take. What kind of medication are we going to give our patient with? So we give our patient with antibiotics, we give our patient with painkiller, with also anti-inflammatory drugs, gastric protector, and also in the day of the surgery we give a kind of medication which is a relaxing medication, which is the Aspin or a Valium, and the patient also takes it before the surgery. But we'll come to the medication next. So we are now in the lower jaw. We start our drilling. As you can see, we have to take in the lower jaw into consideration where we have the coming out of the nerves, where we have its loops, and then in order to place our implant with a tilting of 45 degrees, trying to get it as more distal as possible, okay, to avoid the cantilever. Now we connect our abutment after using the bone mill. As you can see here, we check with the abutment guide and we use the 30-degree 4.5 millimeter abutment. So we go to the other side, we do exactly the same. So our implant is tilted with more or less 45 degrees. In the front, we are placing NP platform implants, which is 375, because here it's thin in the anterior area, and we connect our multi-units, 2.5 millimeter multi-unit abutments. We suture everything very well, and then we make an impression using our impression cuppings. We make again a fertilized impression, as you can see. And then it goes to the lab. So now we have the two impressions. What we are going to do now is we are going to realign our prosthesis. So we have the cylinders of the prosthesis in the upper jaw, and we are going to position exactly where we want our prosthesis in the upper, okay, according to the lip support, according to the exposition of the teeth, according to the smile line, and according to the vertical dimension. We check where we want it to be. We realign also the lower ones, okay, and afterwards what we are going to do, we are going to sand both of the prostheses. Here we just do a bite to check that we have the same articulation in the lab, okay, and we just send it to the lab for them to finish, which means that in the lab they will basically do our stone models, okay. So we have the stone models of the upper and the stone models of the lower with the gingiva. So we can see it here. And now we have both of the models. We like to have always the models, although you did not need it and you could realign everything chair side, but we like to have it because of if something happens, if they have any problem with the prosthesis, if it breaks, if something happens, we like to have the stone models with us in order to fix if something breaks or if we need to realign something. So it's very, very important to always to have the stone models. But if you want to realign and to capture all these 4 cylinders chair side, that's also okay, no problem. So realign all the 4 cylinders, as you can see here. And we are going to reline again the interior ones so that basically we don't have any bubble in the ones in the front, any saliva. Sometimes it's difficult. We can have some problems, and then the connection between the cylinders and prosthesis will be then like a weakest point there. So it's very, very important that you have everything very well relined. Now we are going to take it out and to finish everything. So what we do is we take away, as you can see, all the gingiva from the palatal side. We make our prosthesis convex, or basically straight, not concave, never concave, so a little bit convex. And we avoid cantilever. So if the prosthesis is coming out in the area of the second premolar, we will deliver a prosthesis, as you can see here in the lower arch, with just 10 teeth. If it comes out in the area of the first molar, as you can see in the upper one, we can deliver a provisional prosthesis with 12 teeth. So then we take out the healing caps, and now we are going to connect our bridges. So we connect the bridge and we tighten it with 15 Newton hour screws. 15 Newton torque. Sometimes the gum has swallowed a little bit, so I go step by step and then just check the occlusion. We want our occlusion to be more focused in the anterior teeth, from canine to canine, more away from the TMJ junction, so that the patient doesn't bite with so much force, because then in one day they have lost the only teeth that they had, so the proprioception, they have to gain everything again. And then in the holes we place some provisional, like ERM, some provisional filling, in order to be able to remove it quickly. And this is our patient after the surgery. Now, the question and reason why we are here today is, what about the post-op care? What are we going to tell our patients to do? What are we going to tell our patients not to do? So the instructions are very clear. In the first days of the surgery, it's very important that in terms of ice, the best anti-inflammatory for the patient is to have ice and cold stuff. Okay, so we are going to ask our patients in terms of instructions to apply pressure with sterile swab for around 30 minutes and repeat this for 15 minutes every time they will feel some bleeding. They will apply an ice pack covered with a towel in the region of the face, matching the surgical area during 15-minute period, and then the rest 10-minute breaks, whenever possible during the 3 days after the surgery. So usually is the first 48 hours that they have tendency to swallow more. So this is where it's more important them to have this ice on their face. So, and try to keep the tongue away from the operated area. Also important not to gargle, not to spit, and not to do sucking movements in the first 24 hours after the surgery, because there is a risk of triggering the clot, and this can cause then bleeding and the delaying of the healing process. Also, ask the patient to rest as much as possible, to sleep with one more pillow for the head to be higher than the body in order to try to reduce the edema. It is important in the next days to avoid sun exposure, and during the postoperative period, tell them that it's normal to have some swelling or to bruise in the face and in the neck. Okay, so sometimes they will feel a little bit of pain or limitation in mouth opening capability. This is okay. If they need, they will take some painkiller medication. They should not have and not make physical exercise activities during the next days, especially the ones that are to put the head down. Also very important in terms of nutrition, during the first 3 days to eat more soft and cold stuff, and progressively to introduce harder and hotter foods. During the period of implants healing, the first 4 to 6 months, try to avoid, especially for the all-on-4s, hard and sticky foods such as bread, grilled meat, and all types of nuts. In terms of medication, very important to understand that our patients need medication after the surgery. Of course, there is several types of surgeries, and depending on the type of patients that we have and the procedures that we do, the medication that we advise our patients to have. So here is a simple protocol specific pharmacologic for the oral implantology. We have, for example, I like to always give antibiotics. I like to give corticoids. I like to give also analgesic to our patients. Basically, what we give is, in simple cases, 1, 2, 3 implants, so single partial cases, I give on the surgery day amoxicillin with clavulanic acid every 12 hours, so twice a day. Prednisolone, 1 pill of 20 milligrams in the day of the surgery and the next 3 days. In the day of the surgery, I give a diazepam before the surgery, 1 pill, so that the muscles are more relaxed, which is the Valium, and also a gastric protector, 1 pill before the surgery. Also, painkiller which I use is clonexin, but you can use another painkiller. I give in the day of the surgery before starting the surgery, but also it can, and the days after are in SOS, which means that the night of the surgery before they go to bed, I advise them to take a painkiller so they can sleep well. And then in the next days, just in SOS. Of course, also in terms of antimicrobial, they will use chlorhexidine gel, will apply chlorhexidine gel in the area of the surgical intervention. If we have bigger surgeries, like for example full arch surgeries, instead of being a 5-day medication, it will be 8 days, starting with the day of the surgery, of medication. What here the difference is that we have at day 4, instead of taking the prednisolone, we will start giving the ibuprofen 12 in 12 hours. This is the only thing that changes. So we give this to the patient, this table, and we advise them to take the medication following this advice. In terms of maintenance, it's very, very important to understand that maintenance is crucial. We have to maintain our patients, we have to maintain our implants, and this is important from starting the day of the surgery and before the surgery. In the first months, what we want, during the osseointegration, the 4 months, we want to lower patient discomfort, we want to induce the healing, we want our implants to osseointegrate without any infection, without any problems. We want our prosthesis to be stable, not to fracture, so we want to have good occlusal load in our prosthesis and very distributed. So it is very important to have a strict oral hygiene maintenance compliance in the first months after the surgery. We, as I said, we start before the surgery with an oral hygiene appointment where we remove all the bacterial plaque with scaling and root planing, and also we'll explain to the patients how the maintenance appointments are going to be. And this is very, very important also for them to understand that they will have a crucial role here. We have to explain how bacterial plague control at home by the patients in the different phases, how they are going to do, and why it is so important. So after the surgery, as I told you, we will ask our patient to use a chlorhexidine gel 0.2% or 0.12% with a very smooth toothbrush. We will have, in terms of oral hygiene appointments, we'll have 10 days. So we have before the surgery, then we have 10 days after the surgery, 2 months after the surgery, 4 months after the surgery, and then the recalls are customized from patient to patient, from clinical case to clinical case, and also depending on the peri-implant pathology risk. So these recalls after placing the final bridges will be dependent on the patient case. So what do we do in these recalls? So we can see this is the patient after the surgery. So what we are going to do, this is an all-on-4 surgery. We are going to remove the prosthesis, and we are going to check how the healing is. So this is a healing after the 10 days. Very nice healing. So we remove the suture. We take away all the stitches, as you can see. So one by one, very careful. We see how the soft tissues are, how they are healed. We look very, very, very careful to them. We check if any of the prosthetic components are loose. We check if we have any suppuration. So we compress the tissues with the 2 fingers to understand if we have any suppuration. We are not going to probe at this stage because everything is healing, but we are just going to check for bacterial plaque accumulation around our abutments, and we are going to use chlorhexidine gel 0.2% around our abutments to clean everything and to induce a better healing. Also on the prosthesis, we are going to clean it very well. If needed, we polish again the prosthesis, and we are going to tighten our screws with a 15 Newton torque. Very nice. Afterwards, also very important is to understand if we have a good control of the occlusion. So if we need to trim any contact, if the patient is biting to both sides the same way, how is the occlusion, how is the interior guides, how the lateral guides, how everything is, okay? So we have to check all of this. Good. Then again, we are going to put some provisional filling in the holes, like you can see here. And that's it. So very important to understand that after the removing of the suture, the patient will continue to use the post-operative toothbrush using the chlorhexidine gel, and can use a rinse of, depending on how the healing is, on hyaluronic acid or chlorhexidine mouth rinse. They will use other means of dental plaque removal, has superfloss between the prosthesis and the soft tissue of the patient, or an interproximal brush. Or after 2 months after the surgery, the patient comes again for the 2 months oral hygiene appointment. What we do, we take the prosthesis out and we make oral hygiene, jet clean of the prosthesis, application of chlorhexidine gel, control of suppuration by finger pressure, and we are going to control again the occlusion of the prosthesis and if there is any fracture or loosening of the prosthetic components. So in all these oral hygiene appointments, it's very important to make a good examination, reevaluation, and diagnosis to motivate our patient and to re-instruct on how to clean better several areas that they are not cleaning so well, to polish, to do some fluor, to determine where it's going to be the next recall, to instrumentate whenever it's needed, if we have like any kind of pocket death and if we have suppuration. So we have to treat when needed the infected areas. So we have, in terms of checklists, we have plaque elimination on the implant or abutment surface or sulcus, calculus elimination on the implant or abutment surface, oral hygiene instructions and patient motivation. This has to be on your checklist, Occlusional examination, check. Prosthesis removal and disinfection, check. Appropriate fit of the prosthetic components, everything is perfect, check. And now let's schedule the next appointment. So periodical maintenance of the appointments, check. So every time the patient that we end the appointment of oral hygiene, we have to make sure that we have done all these checks on this list. So after the 2 months appointment, the patient will start to use a soft or a medium toothbrush and can use now chlorhexidine gel or start to use normal toothpaste, but not with a whitening toothpaste or toothpaste with granules, okay? And besides this, besides using also the dental floss, the super floss, interproximal brushes, they can start to use the electric toothbrush and the subgingival irrigator according to the instructions of the dental hygienist. In cases, for example, of zygomatic implants, we do not advise to use the subgingival irrigator. In the other cases, yes, cases of bridges, to use the subgingival irrigator. Single cases, also no need for subgingival irrigator. In the 4 months of maintenance appointment after the surgery, we'll check again the oral hygiene of the patient, to do periapical radiographs, application of chlorhexidine gel, and check for any inflammation of infection. So if we do not have any bone loss, if we don't have any inflammation or infection, the patient can now go already to the prosthetic department to do the final rehabilitation, the final bridges, upper, lower, single, partial cases. In the immediate function cases, with the provisional, we remove also the prosthesis, clean and disinfect, we control the occlusion, and check any fracture or loosening of the prosthetic components. So from the day of the surgery till the 4 months after the surgery, basically they will continue to use the oral hygiene. They will do the oral hygiene as actually I told the last appointment. So they will use a soft or mini toothbrush and with the toothpaste. They will not brush with whitening toothpaste or toothpaste containing any granules. In terms of mechanical means of dental plaque removal, dental floss, super floss, interproximal brushes, electric toothbrush, and also subgingival irrigator are basically tools that they can use in order to remove the bacterial plaque around their implants and rehabilitations. So after the insertion of definitive rehabilitation, they will come for the appointment, and then usually the oral hygiene appointment depends on case to case, will be in 4 months or 6 months, depending on the patient, depending on the type of case, and also depending on the risk that we have in having peri-implant disease around their implants. So every time we'll check the final rehabilitation, we check the occlusion, check the inflammation, disinfection of everything, and schedule already the next oral hygiene appointment. In terms of one time per year, we will do also annual periapical radiographs, and we will do a removing of the prosthesis for disinfection and cleaning and testing the implants in terms of infection and stability. Also, one thing that we like to use that was adapted from the maintenance, the cumulative interceptive therapy that was described by Mombelli and Lang. We use the maintenance protocol, in which what are the evaluated parameters that we have from that? Well, basically, we evaluate the bacterial plaque, the bleeding on probe, suppuration around the implants, bone loss, mobility of the implant, and pocket death. In terms of bacterial plaque, we know that pathogenic bacteria around teeth can and will colonize implants. This bacterial colonization, they will stimulate the immunity, and basically they will lead to bone destruction. So the inflammatory response and peri-implantar infection, that's the consequence of the accumulation of bacterial plaque. So it's very, very important to have a good maintenance protocol around our implants. So we need basically to create the ideal anatomy in the patient mouth so that he is able to have a correct oral hygiene and not and avoid the accumulation of the bacterial plaque. Another parameter that we evaluate is the bleeding on probe. For that, we use the calibrated probe that when you do the pressure, it will only let you do a pressure less than 0.25 Newton. And it might be associated to disease, but also to health. There are several studies. In these cases, in this study, for example, 42.2% of the implants with stable bone level had bleeding on probe. So to say that peri-implantitis is associated when we have bone loss plus bleeding on probe is basically inappropriate, because 90% of the implants with stable bone were found to have bleeding on probe. But Albertson said that it is a predictor factor for peri-implantitis disease progression. Bone loss is I would say the best parameter in order to understand if we are having peri-implant disease. Progressive bone loss, in order to evaluate it, basically we have to always to have follow-up x-rays, and the reference point can be either the day of the implant placement or the bone level after prosthesis, after the fine bridge placement. It is normal to have bone remodeling after the first year of implant insertion. We have to understand that when we talk about the bone loss, it's very important to understand that we are talking about a 3D defect. So the bone defect, for example, in terms of criteria, it's similar to a bone loss, basically mesial, distal, vestibular, and palatal. This is usually what type of bone loss that you have around your implant. The bone width, the maintenance or not, can have maintenance or not of the bone walls like buccal and palatal or lingual. And this radiographic evaluation must be very, very, very careful evaluated, especially when we are talking about periapical x-rays or orthopathomographies, where we have only two-dimensional evaluation of these radiographs, and we are talking basically about three-dimensional defects. So the best way to evaluate would be through also a CT scan or CBCT. So, for example, we can check here in this type of X-rays and the corresponding bone defect that we had around our implants. So we have to go very, very, very careful. In terms of pocket depth, it is also important to understand what does it mean to have pocket depth more than 3 millimeters. We use for that also the same calibrated probe. This does not induce damage in the peri-implantar tissues, and is it more than 3 millimeters mucositis or peri-implantitis? Well, basically, we know some definitions. Some authors say that more than 4 millimeters of pocket depth with bleeding on probe with bone loss is peri-implantitis. Some of them say that less than 9 millimeters can still be a clinical success. So it's always been a very, very big discussion around the pocket depth. So it's a weak diagnosis method for peri-implantitis. Now, suppuration. For suppuration, we evaluate using 2 fingers with depression, as we saw in the video. Basically, it's a dichotomic evaluation where it is present or absent. The presence of suppuration is associated with infection and associated to a bigger progression of bone loss. Mobility, unfortunately, it can occur in the final state of disease progression. It's an indicator of implant loss. So whenever you find mobility around the implant, the treatment is to remove the implant. So when it comes to our evaluation of our maintenance protocol, when it comes to the cyst, again, basically this is a cumulative interceptive therapy where we can see the evaluation, the pocket depth less than 3 millimeters. And what we do is, having it bacterial plaque or not bacterial plaque, we will do always a mechanical debridement and polish and scrape. So this is the non-surgical treatment. If we have a pocket depth of 4 and 5 millimeters, we will do exactly treatment A, which is the mechanical debridement, polish and scrape. Plus, we will rinse, ask the patient to rinse with antiseptic chlorhexidine 0.12% to twice a day for 3-4 weeks. In the maintenance for that, we use, for these mechanical methods, we use the rubber cup, the curette, and the ultrasonic scalers. Chemical methods, we use supragingival application with chlorhexidine and saline solution, and subgingival irrigation with chlorhexidine and saline solution. Also, some antibiotics can be given whenever in terms of chemical methods if we have, for example, a case of suppuration. If we have pocket depth more than 5 millimeters and with BOP suppuration, yes or no, and no bone loss, we will do just also like we see here, treatment A and treatment B. We are talking still about mucositis with no bone loss. By the time we start to have bone loss, but it's still less than 2 millimeters, it can be considerable the normal healing and the normal bone remodeling around the implant. And then you have to realize if you still keep in the non-surgical method, which is to add, because if you have separation, to add antibiotics, local or systemic antibiotic therapy, or if you go for surgical therapy, meaning resective or regenerative surgery. Usually, resective surgeries are more advised to the posterior areas or non-aesthetic areas, while regenerative surgery is advised for anterior and aesthetic areas. So if we have also pocket depth more than 5 millimeters with bleeding on a probe, separation, and bone loss, or what the advisement treatment is to go for a surgical treatment. So all the other non-surgical treatments are tried before, but in this case, it's advised to go for a surgical treatment. And of course, when the implant has mobility, as you can see in the last, then the explantation of the implant is the treatment to go. So this is the just a case of when we go for a maintenance therapy. So we remove the prosthesis, we check on the abutments how everything is, we have bacterial plaque accumulation. As you can see, we check if we have any separation. This is just the bacterial plaque that we are going to remove. Now we see if we have any bleeding. We clean everything very well. We check and we probe around our implants. And now we disinfect using a rubber and chlorhexidine gel. This is our top hygienist, Miguel Nobre, performing it. And now we are going to connect our bridge. So we connect our bridge using our screws connected with 50 Newton. And now we close that holes with the filling that is a provisional filling. Good. So in this case, it is important to have always this maintenance after the osseointegration and the final rehabilitation. Why? Because we want to increase long-term success rates. We want to monitor the tissues around the implants. We want to maintain everything very aesthetic and to keep the final rehabilitation in excellent conditions for oral hygiene for the patient at home. So we know that peri-implantitis is something that can happen. Unfortunately, it's pathological inflammatory changes that occur in tissues around a loaded implant, can be induced by bacterial plaque with bone loss around a functional implant, more than 3 millimeters of bone loss with bleeding on probe and or separation. And basically, it's described also as a redness and swelling in the mucosa, bleeding and separation around our implant and bone loss. So this disease, pathology, peri-implantitis, the peri-implant condition is something that we always have to be aware. Many times the patient doesn't have any symptoms, so it's very, very important that we detect it as early as possible because it has a high prevalence, but it differs from paper to paper, when we look on the implant level or on the patient level, it's really different when we can see that we have rates from 1.4% till rates of 53%. So this is really, really different. And when we look at the meta-analysis, we can see it from at year 2013. There is something that can that has a prevalence in terms of implants of 9.6%. So 1 in 10 implants basically can have a chance of having peri-implant disease. So the secret for this is try to avoid it, and for that the maintenance is the goal and is mandatory to avoid this peri-implant disease, to avoid any biological complication, or to avoid any of the mechanical complications. So what we want with this maintenance and with all this treatment is to increase the implant survival. We want to have always small pocket depth, less than 5 millimeters, and no suppuration around our implants. We want to stabilize the continuity of bone loss. So we do not want to have more bone loss and continue to have bone loss. And we want to remove the biofilm and to control its removing and its controlling by the patient. And of course, we want to diminish as much as possible the risk factors that we have to induce infections, the risk of infection around our implants. So again, the prevention, the maintenance is basically the secret for all of this, for the success, for the long-term success, is the prevention, the maintenance, the compliance with the patient. We can see from all the studies around that there is a high recurrence of the peri-implant disease, as I said. So it's very important to have maintenance programs to diminish the development of the disease. It's important to understand that basically, if the patients are aware that they have the capacity to diminish the possibility of the peri-implant disease, and they have an active role on that, they will go for that. So we know that from the several studies that non-compliant patients, they develop more frequent peri-implant disease versus patients that were in maintenance programs. So maintenance programs should be customized based on local and patients' risk factors. So what I advise to you is that you build your own program of maintenance to your patients, and that you are able to adapt it to each one of the case, each one of your patients, and to customize. Because at the end of the day, what you want is not only to have immediate success on the day of the surgery, but you want to have long-term success of your rehabilitations in your patients. So thank you very much for listening to me once again. And I'll give you here again my social media channels where you can contact me, where you can write me. Please feel free every time to share with me your cases, your doubts. And basically, we are coming to the end of the 8 lectures, and I hope you enjoy them, and I hope they have increased a little bit your knowledge, your clinical knowledge on implant rehabilitation and surgical implant placement. So thank you very much, and we stay in touch. Good. Good. I'm tired. Was great working with you guys. Please, when you come to Lisbon, tell me. Hope to meet you soon also. Bye bye. Take care. We'll have probably more projects in the future. Let's see.